Hello, and welcome back to the part 3 of Unfreezing the Truth of Frozen Shoulder. Dr. Peng, in part 1, you told us that the mainstay management of frozen shoulder was physiotherapy. But you also told us that some patients may actually need interventional therapy. Can you tell us more about this intervention?
Yes, let me just talk about the type of interventions. By far, the commonest type of intervention is intra-articular injection. And in terms of a technique, the conventional technique is to inject a small volume, like 5 ml of those injected, which basically is local anesthetic and steroid. There's another technique in which we artificially distend the capsule, we call hydrodilatation technique. And the volume range from 15 cc to even 100 cc, but I would say most of the literature suggests only 20 to 40 cc. Some investigators, they even try to give a very high volume to deliberate to rupture the capsule to obtain the maximum effect. In terms of approaches, there are two approaches. One is to put the needle from the back, we call posterior approach. The other is the anterior approach. They put the needle from the front, we call anterior, and mainly the rotator cuff interval approach. But for the posterior approach, we typically use ultrasound to insert the needle from the back, and here's the ultrasound image. You can see the glenoid and the labrum, and most important is we put the needle from lateral to medial, just insert the tip, just dip to the tip of the labrum. For the anterior approach, we talk about the rotator cuff interval is a good cross-section image. The roof is coracohumeral ligament, and the most important structure you can see in the middle is the long half bicep. We tend to put the needle from lateral to medial, just touching the top or the superior part of the bicep tendon, and then we inject the medication. In addition to the joint, we also have another approach, basically we call the nerve block, the suprascapular nerve, which is a very important nerve supplying all the pain input of the shoulder.
Wow, there are a lot of variations then. But how would we know which one to pick to have the most optimal approach?
Well, let's zoom back to look at that picture. The first role of injection is pain control by putting some anti-inflammatory medication, that is steroid. The recent systemic review clearly shows that application of the intra-articular steroid injection provide benefits in both the pain and the function in the short term. But unfortunately, the short term varies between literature, and sometimes they say 6 weeks and sometimes they say 2 months. The second role of the intervention is to provide hydraulic pressure to stretch the thickened and contracted joint capsule and what we call the hydrodilatation. Now compare hydrodilatation with the simple intra-articular injection. There are two systemic reviews. One review showed hydrodilatation confer additional benefit in function in short term, while another review showed just additional benefit in pain in the short term. Some physicians deliberately use a very high volume to rupture the capsule to allow some extra-articular spread, yet it does not confer any additional benefit as shown in this study. The main reason is highlighted in this article, and it suggests that the rupture mainly occurs in the subscapular fossa and along the subacromial bursa, not the anterior capsule or rotator cuff interval where the adhesive capsulitis originate.
So, Dr. Peng, you also mentioned there's two approaches, one inserting from the front and one inserting from the back of the shoulder. They should have the same effect, right?
People tend to think that way because no matter you put the needle front or back, you end up in the same joint. Well, the outcome is different. A systemic review published recently show that the rotator cuff interval approach consistently is better than the posterior approach in both the pain and function.
That's kind of strange because we're putting a needle from the front and the back in the same joint though. But how would that make a difference?
It's quite a story. A lot of people are not too sure why there's a difference, but that's the reason why our team tried to look at this. Basically, we published two studies. One is the cadaver study, the other is the human study. We find that whether it's anterior or posterior approach, you end up in a joint, that's for sure. But when you inject into the rotator cuff interval, it tends to spread not just inside the joint, but also in the pericapsular structures such as coracohumeral ligament, as shown here. Remember I mentioned in part 1 that the fibrosis and contracture affect not only intra-articular structures, but also the pericapsular tissue. Rotator cuff interval, in that case, can reach both targets. That's why it may give the theoretical advantage.
That is so interesting. But you also did mention the suprascapular nerve block, right?
True, suprascapular nerve is another approach. Instead of injecting into the joint, it provides a nerve block interrupting the pain signal. This procedure had been described a long time ago, and these are the good summaries. In general, suprascapular nerve provides 45% of the joint innervation in the superior and posterior aspect, as well as the surrounding tissues. However, this is the area where most of the nociceptive fiber concentrated, whether it's intra-articular or extra-articular. So it's a very useful procedure to capture all the painful signal from the shoulder. A recent review shown here gives us some optimism about the usefulness of this procedure in frozen shoulder, and they show that the efficacy is comparable with the intra-articular steroid injection. But I think more research is needed to define the exact role of this in the management of the frozen shoulder.
Oh, that's great. But when should the provider refer the patient for the nerve block?
Good question. Remember we talked about the mainstay of treatment of the adhesive capsulitis is
Physiotherapy,
physiotherapy,
and
and
physiotherapy.
So it's important that the provider who provide the physiotherapy know when to refer the patient back to physician to ask for some help from pharmacological or interventional procedures. Elena, remember some time ago I shared an old article for you regarding the irritability of the soft tissue around the shoulder?
Yes, I do.
Patients with frozen shoulder come with different stages of presentation, with different degree of pain and stiffness. But most important, they also varies in the irritability of the soft tissue. That means sometimes the pain can be more intense than the other patients. This article suggests a conceptual framework on the degree of irritability to help provider to understand different type of patients. Elena, remember in episode 1, we tried to convey a couple of messages about the management of the patient. Do you still remember that?
Yes, I do. Although literature suggests a classic three-stage natural history, the duration and presentation of each stage varies with patient. Some patients may have the inflammation and pain for a long time, and some have very resilient fibrotic stage. Number 2, the loss of passive range of motion is not all related to the structural fibrotic change. There may be element of muscle stiffness, which can be related to pain or psychological factors, such as catastrophizing thoughts or fear avoidance.
Very good. The article we just mentioned divide the patient into 3 groups depends on the tissue irritability. On one end of the spectrum, they describe the patient with high irritability. They usually have a high level of pain, with pain at night, at rest, and also the pain occur before the end range of the active or passive movement. The moderate irritability is in the middle. They usually have a moderate level of pain, and usually the pain occur at the end range of the active and passive movement. On the other end of a spectrum is a low irritability. Usually patients have a minimal level of pain. They don't have nighttime or resting pain, and the pain only occur when you try to overpressurize into the end range of the passive movement. So for those with a low irritability, there's no need for any pain intervention procedures. But for those with a high irritability, I think it's a time to consider refer to the physician to consider either medication or interventional procedures. In the middle group, when the pain or irritability is moderate, it's up to the discretion of the provider.
Wow, now that is great. Dr. Peng, in the last 10 minutes, you have covered the types of interventions and when we should consider those interventions. Now we conclude the 3rd episode of Unfreezing the Truth of Frozen Shoulder. Thank you for watching, and if you like these episodes, click the like button.